بسم الله الرحمن الرحيم. This recording for the seventh part of the cardiology review will have example of ECG, hemodynamics, echo, cardiac imaging, CAT, and A/B tracing. So starting by the ECG, look for this ECG. Look for the main 6 items in the interpretation of the ECG. Look for the rate, rhythm, axis, interval, chamber enlargement, segment, and wave changes. So in the ECG, there is a sinus rhythm or a normal sinus rhythm, except when there is premature ventricular contraction. Premature ventricular contraction coming mostly as BVC alternating with normal conducted beats. So the coding for this ECG is sinus rhythm or normal sinus rhythm with BVC. Second example for this patient have two ECG. On the day one, they do for this ECG, do it for him, which on this ECG, when we can see the previous sinus rhythm and the left axis deviation, due to abnormal activation of the ventricles, abnormal activation of ventricles, more clearly seen in the V3 of this ECG, where we can see the V3, there is short PR interval and delta wave. So and here to comment well in the segment wave changes, need to see all lead or to see the lead in anatomical way. So lateral lead, period lead, septal anterior, and apical leads. So here we can see there is a delta wave. So sinus rhythm, except when there is a delta wave, it's compared with next day ECG, which shows normal sinus rhythm or normal ECG. So sinus rhythm and intermittent excitation, WBW. This is an example for a man who presents with syncope or fall down, where you can see the rhythm is the atrial flutter, axis is left axis deviation, no other abnormality in this ECG. So atrial flutter and left axis deviation. And this example of the pacemaker, well-functioning pacemaker, which is a type dual chamber pacemaker. This is a for a tachycardia, which is a narrow-complex tachycardia. By approaching the narrow-complex tachycardia, we found this there is no B wave for Charles complex, and the B wave is retrograde, small in the ST segment, and RV is very short. So this is it's a perpendicular tachycardia, if you know the entry tachycardia. Other than this, there is the left axis deviation. So electrophysiological mechanism of the avenodal reentry tachycardia when there is induction of the BVCs or atrial pulsing in the epilobe, or when there is premature ventricular contraction. The premature conduction beats coming will find the specific way is blocked in effective respiratory period due to previous beat normal beat. So the premature atrial contraction will go through the FA node through the slow pathway in patient who have dual FA nodal histology. So we'll go through the slow pathway to the ventricle and then retrograde coming back to the atrium. We found the fast pathway. Refractory period is finished so that the beat will be reconducted again to post the COVID and cycle of the SVT was started. While this is epinuderant tachycardia, what about the FERT? FERT either divided into orthodromic or antidromic. Orthodromic when there is activation of the atrium conducted from the FE node to the ventricle and coming back to the atrium through the axillary way. while antidromic, when the conduction of the AFE node is transferred to the ventricle through the axillary way and conducted back to the atrium through the AFE node. When orthodromic nerve tachycardia, the Car's complex time is narrow because we are conducting through the uh, normal conduction system, but the retrograde conduction is through the axillary way. While antidromic white complex tachycardia, we are conducting or the patient's electrical activity coming to the ventricle through the axillary way and conducted back to the atrium through the phenol. So we call this is white complex morphology. What about this patient has 60 years old with palpitation? How to approach this? This is in general is white complex tachycardia. This white complex tachycardia could be or mostly ventricular tachycardia and can be supraventricular tachycardia with either aberrancy or any other causes of the white complex tachycardia. So how to identify this is ventricular tachycardia, which is more important and more easy to diagnose. Look for the ECG morphology, access intervals, look for the history. So how to approach? This ECG showing white complex tachycardia. Morphology is atypical right bundles, is more basic R wave. Right bundle morphology with Caras complex is one more than 140. Extreme axis deviation, dominant R wave in FER. So all these features are supporting ventricular tachycardia. Also, we have AV dissociation, which is very specific for the ventricular tachycardia. So approach to the diagnosis of chronic tachycardia. If you have white chronic tachycardia, so we are 80% of the time you are dealing with fetal. If you give the history that patient is more than 35, it is likely this patient is presenting with ventricular tachycardia, which positive predictive value is 85% in one of the series. SVT more likely to become in younger people, which has lower positive predictive value. Braille myocardial infarction is very helpful to diagnose patients is ventricular tachycardia. So if we give you a history that patient is presenting with white complex tachycardia, before looking to the ECG, we are dealing 90% dealing with ventricular tachycardia. Other features that is helpful is epidissociation. Find it is very specific for ventricular tachycardia. Then capsular fusion beat, then northwest axis identified by the presence of the negative complex in lead 1 and lead FF. Concordance mean all the recorded lead either positive or negative. This is mean concordance. Initial R wave in FR, initial K wave more than 40 milliseconds in FR. Morphologic criteria either atypical right bundle or atypical left bundle, and with criteria if right bundle morphology corresponds more than 140 supporting free tag, left branch morphology occurs more than 160 milliseconds, going with the theta. Next for the CCG, where we can see patient has sinus rhythm, if it's sinus tachycardia, the atrial beat is dissociated from the ventricular beat. So this patient has complete heart block. With the subsequent pacemaker is junction rhythm. Is junction rhythm around 35, 38 beats per minute. And we have right bundle morphology. We have uh, left axis deviation. In this left axis deviation is not the same symbol of axis deviation is left anterior classical lock because we are seeing Q, small Q dominant are laterally lead 1 and APL, and we are seeing small R dominant or deepest the inferior lead. So this is left anterior classical lock with left bundle branch, oh sorry, with right bundle branch block and complete leading to complete heart block. So this patient is symptomatic, need to have pacemaker. So complete heart block, sinus tachycardia, right bundle with left anterior classical block, escape rhythm. Next for this patient, we have this ECG, we have V wave, then Cardiology, then another V wave without chaos complex. To identify clearly the B wave, second B wave, is this B wave coming on the top of the T wave. We can identify clearly from P1 and also from P3. We have seen the B and this and the T wave. And the B wave, especially in P1, is similar morphology. So that you have 2 to 1. This 2 to 1 hard block either mode second degree mode type 1 or second degree mode type 2 can be differentiated by the exercise elevation, getting atropine, differentiated does it super Hessian where we can respond to atropine activities will make the heart rate is better and make heart block is less or not responding to this measure. So this is infrahessian heart block. Next, for this patient with this ECG showing a left-handed morphology where we can see the pacing spice for the ventricles. This pacemaker, what is single chamber pacemaker, is VVI pacemaker. You can also confirm this VVI pacemaker that the ventricle activity has no relation with the activity. So the pacemaker is activating the ventricle at certain rate without looking for the atrial activity. Does it conduct to the ventricle or not? So sinus rhythm, base ventricular rhythm, VVI. Next, for this ECG, where we can see the patient first actually has sinus rhythm with axis is left axis deviation. The second B wave is not conducted. The rate is very slow. Is around 60 to 75. So sinus rhythm at around 60 75 beat per minute. And we have preventive ventricular contraction. This patient has second degree heart blocks, 2 to 1 heart block, likely is Mobitz type 2, because he has also right bundle branch block, has left anterior fascicular block, because we have QR in lateral lead, small R dominant is inferior lead, so anterior fascicular block, and right bundle branch block, likely infrahessian, and in Mobitz type 2 to 1 heart block, also have premature ventricular contraction. So second degree sinus actually, it's not sinus ready. Second degree heart block with type 2, premature ventricular contraction, left anterior fascicular block, and right ventricular branch block. So what's about hemodynamic tracing? In hemodynamic tracing, look for ECG, look for the where the tracing is measurement. And they are like of periodic tracing from the LV and from the left atrium. So to catheter, when look at the LV, it's measure the LV. We couldn't see the highest pressure in the LV, but we can see the diastolic pressure of the LV is normal. That early diastolic pressure and late diastolic pressure is normal while the atrial pressure is high during the stall and during the stall. What's suppose during the stall the atrial pressure and ventricular pressure are equal when in one except in one event when there is mitral stenosis the left atrial pressure is not equal to left ventricular pressure and this is demonstrated by this example. There is a gradient between the left atrium and the systolic pressure and left ventricular systolic pressure. We know during the diastole, the left atrium is evacuating the blood, first be the activity, then being the atrial contraction in the sinus rhythm. But here we have a gradient between the atrium and ventricle, indicating there is stenosis. Likewise, in the ventricle, the ventricle systolic pressure in the ventricles will be equal to the aortic pressure. If there is a gradient between the left ventricle and the aorta, the systole is only due to aortic stenosis. So here is metastenosis. Also, we have seen the systolic wave is very high. So most likely the patient also have been mitral regurgitation with mitral stenosis. Here another example, the left ventricle pressure. We are seeing the left ventricle pressure. Diastolic left ventricle pressure is okay, but late diastolic ventricle pressure is elevated. And we start seeing pulmonary capillary pressure. This pulmonary capillary pressure is indirect measurement of the left atrial pressure. And pulmonary capillary pressure is high, is sky high during systole. What's the cause to maybe the ventricular left atrial is elevated during systole because presence of mitral regurgitation. Also, with this V wave, the different diagnosis for this is severe mitral regurgitation or acute severe mitral regurgitation. Another hemodynamic dressing for the LV and RV during inspiration and expiration. When you are seeing the inspiration and expiration, or you see the respirometer, this give you a hint that you should look for the um, pressure of the LV during inspiration and expiration, and if there is any interventricular dependence or discordance between the right and left ventricles. As you're seeing here, the right ventricle pressure during inspiration is increased because venous return is more to the right ventricle during inspiration. So RV pressure is elevated during inspiration. This leading to the decrease the LV pressure. What's the causes of the decreasing LV pressure? Because the LV has less blood flow and the symptoms will be pushed from the RV to the LV. Because why the symptom is pushed from the LV to the RV? Because the myocardium is constrained by the uh, pericardium. So when the myocardium constrained by the pericardium, so there is no way for the RV to expand except pushing the septum in toward the LV. So this is what's called a ventricular interdependence, depending on each other. So the LV pressure will be decreasing while RV pressure will be elevated during inspiration, while during inspiration the venous return to the through the pulmonary veins to the LV is more, so the LV pressure will be elevated. This will be accompanied by decrease the RV pressure. So this is diagnosis constricted pericarditis. Coming to the echocardiography, as you see here, the RV is very big, it's dilated, severely dilated, so the symptoms is fluttering during systole, during indicating pressure overload, the left ventricle is normal size, contracted, the basal segment is okay. Here we see the hepatic veins is dilated, and the renal vena cava is dilated and collapsing. Also, we're seeing either the LV to RV, the LV RV size is usually dilated compared to the LV, and the symptoms is pushed to the LV, indicating high RV pressure, and here the pulmonary uh, valves, and here the tricuspid valve with tricuspid regurgitation. There is tricuspid regurgitations. Here short access at the mid segment, also flattening in the symptoms, dilated RV, dilated RV with apical fourth chamber, showing dilated RV, impaired RV systolic function, normal LV systolic function, parasternal axis showing that the symptom during systole, normal emphasized systolic function, dilated right ventricle, and impaired RV systolic function. The most showing flattening of the symptom during systole and diastole is very important indicator pressure overload. Here the continuous wave Doppler in the RVOT, and there is RVOT of this wave Doppler notch. Um, if you do, if you want also see typical picture and also by Wilson Doppler, short acceleration time is around 70 milliseconds here, and there is uh, there is notch during systole indicate high pulmonary artery systolic pressure. So we'll go to next. Next, the fortitudolar indicated RV systolic dysfunction, tricuspid regurgitation continuous wave Doppler indicate the tricuspid gradient is 31. So RV systolic pressure is 31 plus right atrial pressure. Here, RV systolic pressure or pulmonary systolic pressure, if there is no pulmonary stenosis, is 35 plus the RV systolic pressure. So incredible pulmonary systolic pressure. So normal left ventricle side systolic function, severely direct the right ventricle with severe reduced systolic function, pulmonary hypertension, C notched RPOT, vasovagal vestibular, vestibular, melatomodirect tricuspid gash, McConnell signs, we are seeing it, and else elevated pulmonary artery systolic pressure. This pulse wave in on the hepatic vein, showing the hepatic vein in the first beat here, small reversal direct systole. In the second beat, there is prominent systolic direct systole. This which of this following situation is coming due to mitral regurgitation, due to moderate or severe tricuspid regurgitation, due to severe pulmonary stenosis or arterial dysfunction, or constrict pericarditis. The correct answer due to moderate to severe tricuspid regurgitation likely presence of severe tricuspid regurgitation lead to the uh, uh, reversal in the hepatic vein. So this is historical cause of hepatic vein for severe tricuspid regurgitation. So this is normal hepatic veins where we're seeing the systole and diastole. When you have constriction, you have seeing experience systolic results, experience systolic results in patients with constrictive myocarditis. Measurement of the pulmonary or putting pulmonary pulse Doppler in hepatic vein should be in mid hepatic vein. So this is the mid hepatic vein, and this is the right hepatic vein, and this is inferior vein again. Here is pulse Doppler from the abdominal aorta, where we're seeing the systolic wave is normal, coming forward and ending during systole. But unfortunately, there is backward flow through the abdominal aorta. When there is a reversal from the abdominal aorta reversal in the abdominal aorta, this indicates only due to severe aortic regurgitation, especially when there is the reversal during whole systole. But if there's early diastole, a whole diastole, but if there is early diastolic reversal, maybe due to hyperdynamic circulation. But whole full diastolic reversal indicates severe aortic regurgitation. Here the image for the mitral valve, where we're seeing the opening, the mitral valve is nice, early and late opening by the wave, but unfortunately during the closure, there is posterior movement of the leaflet, both anterior and posterior mitral valve leaflet. This indicates collapse both anterior and posterior mitral valve. So there is a prolapse of both anterior and posterior mitral valve leaflet. Sorry, this positive developer of the mitral valve with the spirometer. The spirometer in the spirometer ascending leg is inspiration, descending leg expiration. Where we can see during inspiration, the left-sided blood flow will be decreased. During expiration, the left-sided blood flow will be increased. There is a variation in the flow, more than 25%, which indicates constrictive myocarditis or cardiac turbulence. This also develops the blood in the from the suprasternal notch, where we can see the transfer part of the descending aorta and the proximal part with the descending aorta. And here, in the descending aorta, they are putting the pulmonary positive wave Doppler signal, and a positive signal showing forward flow during systole. But during the systole, there is a reversal of the flow from the proximal abdomen, proximal part of the descending aorta, indicates moderate or severe aortic station. Here is continuous wave Doppler from the PST with peak velocity 6 centimeter, 6 meter per second, 6 meter per second, and the blood pressure of this patient is 174. Why the blood flow from curve from the for the PST? When the left ventricle systolic pressure is higher than the upper pressure, the blood will come from the left side to the right side. As we said previously, if we have no aortic stenosis, the left ventricle systolic pressure is equal to the aortic pressure. So systolic pressure here is 174. So left-sided systolic pressure is 174. So we'll push the blood from the LV to the RV if there is difference in the pressure between the LV and RV. How much is the difference on the pressure? From this difference in the pressure, we can measure the pulmonary artery systolic pressure or RV systolic pressure. So the RV systolic pressure equals 174 minus 60x squared times 4. 60 squared times 4 will be around 144. So 174 minus 144 will be 30 millimeter mercury. So right ventricular stimulator is 30 millimeter mercury. This is how to calculate. Next examine the echo. Here the echo showing severely dilated left ventricle and severely reduced systolic function. Uh, here E1 to certain severity is very widened, normally less than 0.7 centimeter, and decrease realized is around -3%. Global hyperkinesis to akinesia, so dilated left ventricle severely reduced left ventricular systolic function. Here is an example showing parasternal lung axis view. There is a basal doming, the aortic valve, normal basal part of the ventricles that has size and function. And here in the short axis of the aorta, we can see this bicuspid aortic valve and fusion between the right and non-coronary cusp. This is the two cusps during systole. To identify the valves, you need to see the cusp during systole. So they coded this normal LP size, normal function, bicuspid aortic. What about cardiac imaging? Here we can see the CT. CT showing RC. RC usually coming in the anterior, while the LCX and LAD are coming in the inferior or posterior. This is the left atrium, this is the aorta, and this is the part of the LP. This is the interventricular septum, this is the artery. So this is the right atrium. Sorry, this is the right coronary artery, and this is the branch of the right coronary artery will be uh, either in the proximal part will be marginal artery or sinonadal artery, or the in the middle part will be artery branch. So we are saying here both are right coronary artery and its branches is okay, will be specified with contrast. But here we can see the right coronary artery is not well specified, and the right and the branch, no branch here, where here you can see the RCN, the branch is well obfuscated with contract. So indicate this middle part, there is a stenosis of the right coronary artery. Corresponding to this to the multilunar construction, we are seeing here the stenosis of the right coronary artery. This is confirmed by the coronarography. There's mid-tight stenosis of the right coronary artery before the branch. So before this branch is coming out, there's tight stenosis of the right coronary artery. Well, in this example, we are seeing the left system. Part of the left system is the left system is divided into anterior part, the left anterior distal artery, and the artery traveling through the FA group to the lateral part, and the part is the left circumflex and its branch or obtuse the marginal part. So here we can see the left circumflex and it's well specified. Here there is less specification with the contrast, indicating there is a stenosis, severe stenosis of the obtuse marginal and left circumflex artery. And this is confirmed by the cholangiography. There is severe stenosis of the left circumflex and the obtuse marginal artery. Here also the right coronary artery, where you can see calcification. Calcification can make our job to identify the stenosis is challenging. So there is calcification, heavy calcification is very bright white part during the calcium scoring and geographic injection of the contrast. This is calcification leading to the stenosis of the right coronary artery. This is confirmed by the coronary angiography. And this example for the safety of the heart, rest of them is okay, but there is a mechanical valve, this mechanical valve connecting between the LP and the aorta. So this is mechanical aortic. What is about the cat? Because we have an example for how to identify LAD or 6. Else we'll have left further view, mostly the front view will be S6 and the upper part will be LAD. And you see the heart is circumferential, rounded shape. While cranial view, we're seeing the cubital diaphragm. We'll see the in front of us the LAD, left anterior descending artery, and we can see part of the left main system and bifurcation. Here example of the left coronary artery injection, where the flow is REO caudal. we're seeing the left circumflex artery in the front of us and left anterior descending artery. We can easily identify the proximal and mid segment of the left circumflex and proximal and mid segment of the LAD by this view. And this left coronary artery injections, and this is the code view. We're seeing left circumflex in front of us and the LAD. In left circumflex, we can see the proximal to mid circumflex and the proximal to mid LAD very nicely. We can examine these two arteries by this view. Uh, left anterior oblique, which is a caudal view, which is another name for it is spider view. We can see the LAD is the upper one and left circumflex is the one, and no copy of diaphragm. And here we have left coronary artery injections, and you are seeing the LAD in front of us and left circumflex there. This is a cranial view, and this indicates we can comment to the Richtman system, we can comment of the LED, proximal mid, almost to distal, and SX, proximal to mid SX later. Also, epicranial, we can comment on the proximal to mid segment and distal segment of the LED. As we are seeing here, the LED mid proximal segment is diseased. Here an example of right anterior oblique canine view is also the L3 will see it front face, L6 will see away. So only by this view we'll comment on the LED diagonal approach. Right coronary artery either LAO or RAO. LAO, we can see the right coronary artery as C-shaped, as you see here. We can see the posterior lateral branch in the up and posterior descending artery down. And this way, in this view, we can comment on the full length of the right coronary artery up to the bifurcations and the proximal part of the distal branches. Here also again for the right coronary artery, area of view, or sorry, area of view. We're seeing the RCA as C-shaped, and we can comment the whole length of the right coronary artery and the bifurcation. And the distal part of the PLB and the PDA, we can see by the same. RCA, RAO, sorry, LAO, LAO is RAO or AB aerial. Sorry, RAO is right anterior oblique, and this is cranial right anterior oblique. We can see the RCA as L-shaped RCA, where we can comment in the proximal mid and up to bifurcation, up to the distal bifurcation, or proximal to full mid segment. We can comment on the RCA comfortably by this view, but we cannot comment on the distal part when it is on the BLD or PDA. We cannot comment from this RCA model view. Lastly, we'll have AV tracing. As you see here, we can see surface G, and we can see right atrial lead, here's CS lead, and RP. Here, look for the first electrical activity. First electrical activity is atrial activity, is B wave. B wave is coming to the ventricles in concentric way. Here we can see the A. Go to the H, his system, and look for the H. Measure the interval between A and H. A is normal, but around between H and V, the H and V interval is 0 or even minus. RVH V interval is 0 here, HV interval is 0 here, RHV interval is 0. This is a good hint. We'll go back to the service view. We are seeing the ECG showing white plus max. So most likely this patient has brexit. So brexcitation, if you have short HV interval, first thing will comment to us is brexcitation. Or if you have a V without H, also brexcitation, because the activity comes from the atrial to the ventricle without passing from the FE node. So that's no spike of the H and of the H when there is no when there is access pathway and no activation of the FE node. So short HV interval due to conduction of the access pathway. Here we can see same is corresponds to the last one. Here see the CFCG and we are seeing an right bundle morphology at the beginning, but is not typical right bundle morphology. At the beginning, the electrical activity is basing the atrium. Atrium is conducted through the edge to the ventricles, here the edge, here the edge. Each ventricle is short, each ventricle is short, but here the edge to V interval is prolonged. Another hint in this example, also in this example, the RP activation is coming after the LP activation, after the chorus complex. This indicates the LP is activated before RP, and this only happen with the presence of the axial pathway. So axial pathway is activating the LP, then activating RP. Here we see the RA bleeds, and then H, then V. Same thing. H to V is very short. H to V is very short. Till we reach here. H, then V. So HV here is around 40 milliseconds. This so normalize HV. Normalize HV, and this is there is ablation catheter. Most likely axial pathway is ablated, and this is successful axial pathway ablation. So ablation of the axial pathway, seeing the last bit, there is big hesitation in the four, and there is short HV interval in the first 6 beats. Maybe this is the last tracing or for the last. We are seeing the surface ECG, we are seeing the في lead or V1 lead is dividing price complex, and we are seeing R this R dash as right the branch morphology. So this A/B tracing for the right mental morphology. Lastly, we are seeing surface ECG with white colors complex, except for second colors complex is not white. This is from the surface ECG. Then go to the intracardiac message, where the highlight the lead, then conducted through the hearse, then V. We can note something. There is no H spike. So electrical activity conducted to the ventricle without passing the H. Other than this, look for the R3. R3 and L3 look for them. And then here also R, H, right atrium, right atrium conducted through his. So there is his spine. Compare this with this. Compare this with this. So second beat here is conducted from normal conduction system. But first beat, third beat, fourth beat is conducted from the accessory pathway. So there is loss of the accessory pathway in the second beat, then accessory pathway continue to work, and there is activation of accessory pathway. There's a delta wave here, we can see the substance CV, and accessory pathway, there is excitation and loss of excitation second beat. Thank you so much.